Hello friends, we'll start now with stomach and duodenum. Both anatomically, both these are two different parts, but they are considered together as they are not different from each other during surgery, because one organ invariably requires help of other organ during surgery. You cannot operate both these two organs independent of each other. So they are considered, their diseases are considered together in this chapter. So we'll go through what is the basic function of the stomach. It is a reservoir for ingested food. It breaks down food mechanically. Process of digestion is started before these products are passed into duodenum in the stomach. So what are the investigations that we have to investigate disorders of the stomach? So first is the flexible endoscopy. Flexible endoscopy is now the gold standard investigation to assess or to diagnose various gastric ailments. Peptic ulcer, gastritis, and duodenitis are mostly for which the endoscopy is done. Upper gastrointestinal bleeding, endoscopy is superior than any other investigation. It can be a diagnostic as well as therapeutic. What I mean by that? So you can diagnose various conditions like gastric ulcer, gastrointestinal bleeding, and you can treat them in the same sitting as together, because gastric ulcer, when it is bleeding, you can treat it by either adrenal injection or by hemoclip. Next we have got contrast radiology. It will diagnose large hiatus hernia when it is seen in Trendelenburg's position. It is maybe a prolong type or it may be a mixed type. Chronic gastric volvulus. When the patient presents with recurrent pain in upper abdomen, chronic gastric volvulus may be one condition which may be missed even on endoscopy. So chronic gastric volvulus can be diagnosed on barium studies. Ultrasonography. Abdominal ultrasonography may not be that sensitive for gastric ailments, but in contrast, endoluminal ultrasound, because the same ultrasound, when it is passed along with the upper GI endoscope, it is called as endoluminal ultrasound. It may serve better function than abdominal ultrasound. Why? Because it will reach directly to the gastric wall and it will avoid skin and all fat organs, directly reach the lesion. So along with endoluminal ultrasound, it's the same principle, intraoperative ultrasound are more useful. Endoscopic ultrasound is the most sensitive technique for the evaluation of T stage of the gastric cancer during invasion of gastric wall in assessment of gastric malignancies. Also, it is also useful in assessment of duodenal ulcers and malignant duodenal ulcers. Computerized tomography scanning. CT scan is now the less sensitive for assessing tumor invasion in the gastric wall because of the availability of the endoluminal ultrasound, which is more superior than CT scan. It can be used for assessing the nodal status, for assessing response to the chemotherapy, for assessing liver metastasis and bone metastasis, but it is not that sensitive as compared to the abdominal sonography or endoluminal ultrasound for assessing metastasis in the liver. Positron emission topography, it is to detect for occult spread in the body for metastasis and to assess the response to the chemotherapy and to prognosticate how much further the spread has occurred. Laparoscopy. When you are on scan, you get nodal status which is more than perigastric nodes. We can proceed with the diagnostic laparoscopy so as to assess, apart from these nodal status, whether the patient has got any peritoneal metastasis or not. So peritoneal metastasis, when they represent disseminated disease and palliation should be offered to these patients. During laparoscopy, you can also collect the peritoneal fluid if the patient has got ascites to have cytological studies. Next we have the gastric emptying studies. These can be used to the motility disorders of the stomach or in gastric dysmotility. This investigation is helpful to assess the emptying time. The patient is given a radio tracer level diet and it is assessed how much percent of the food intake which gets emptied at a given end of time. Apart from gastric emptying studies, now we have got angiography. Angiography is very important for assessing bleeding duodenal ulcers or bleeding gastric ulcers when they are not controlled by routine endotherapy. Also, when you are in postoperative status, if you have got upper GI bleeding from any of the suture lines or any of the gastric arteries such as celiac axis, angiography is very versatile to diagnose and to treat upper gastrointestinal bleeding. It can be used for obscure upper gastrointestinal bleeding or it can be used for therapeutic embolization of a bleeding vessel in the gastric or duodenal region. Now we go to the Helicobacter pylori. This is the bacteria now causing most common infection in humans. So it can be seen in a diverse array of presentation like chronic gastritis, peptic ulceration and gastric cancer. So we'll go through how these bacteria affects in the gastric mucosa and how these lesions are produced. So when the bacteria is present in the gastric wall, it will hydrolyze urea and ammonia is released, which is alkali. It is very strong alkali. Once the strong alkali comes with the gastric mucosa, then it will release the gastrin by antral G cells. So once the gastrin is released, so it will lead to the formation of gastritis along with gastric ulcers. Now, how to diagnose H. pylori infection? It is by 13C and 14C breath tests, or it can be done by the urease test performed on the gastric biopsies, or it can be used with diagnosis with various stains. These are Gimsa stains and Ethine Stilwer stains, or various serological tests which can diagnose a past infection, also the present infection. How the pathophysiology of gastric ulcer or gastritis is caused by H. pylori. The H. pylori will produce the cytotoxins, notably CAG-A and VAG-A. These are gene products. These cytotoxins cause gastritis, peptic ulcers and gastric cancers. Gastric metaplasia in duodenum is response to the duodenal mucosa to excess acidity. So in some cases, H. pylori infection not even remains restricted to the gastric mucosa, but the ulcers are seen even in the duodenal mucosa. So how this happen? It is explained by this reason. Whenever there is increased acid production, there is metaplasia in the duodenum, which will harbor now it will become more friendly to the H. pylori infection. So the H. pylori will go and attack this cell and will form more gastric acid secretion and it will form various ulcers. Different environment have different manifestations, because in low social strata you will find more infection of H. pylori, whereas gastritis affecting the body of the stomach, it is common in developing world. It may lead to the hypochlorhydria and gastric neoplasia. What the treatment we have got for H. pylori? The proton pump inhibitor along with the 2 antibiotics, which we will call as a regimen for H. pylori infection, can be given for the patient for 14 days. The metronidazole and amoxicillin may form a part of antibiotic therapy. If you add clarithromycin to it, the clearance rate may reach as high as 90% and the relapse or recurrence rate reduce. Now we will go to the various types of gastritis. We have got 2 main types of gastritis. These are type A gastritis and type B gastritis. Now we will go in detail of type A gastritis. Type A gastritis is an autoimmune gastritis. We have got antibodies to the parietal cells. The parietal cells are destroyed by autoimmune nature and it will lead to the hypochlorhydria and achlorhydria. When the parietal cells are destroyed, it will also lead to the malabsorption of vitamin B12. It will cause pernicious anemia. In type A gastritis, the antrum is not affected and the hypochlorhydria leads to the production of chronic hypergastrinemia. In response to decreased acid, the gastrin is stimulated so that it will increase the gastrin levels. Once the gastrin levels in the body rise, it will produce the hypertrophy of the ECL cells of the body of the stomach, which are not affected by autoimmune damage. Once this hypertrophy of the cells occur, it will produce multiple microadenomas. Microadenomas can become malignant. So how autoimmune gastritis or the type A gastritis is more prone for gastric malignancies. Now we will go to the type B gastritis. It is called H. pylori infection. So H. pylori infection, what we have learned earlier, will produce type B gastritis. It will affect mostly the antrum. Patients with pan-gastritis seem to be more prone to the development of gastric cancer. In short, the autoimmune gastritis will also lead to the cancer more commonly as compared to the type B gastritis. Patients with pan-gastritis, they have intestinal metaplasia associated with chronic pan-gastritis. The intestinal metaplasia associated with the dysplasia has significant malignant potential, and if this condition is identified, endoscopic screening can be suggested to the patient so as to avoid invasion of the malignancy in deeper layers. Now we have got reflux gastritis. So it is more commonly seen after gastric surgeries. It is the histological feature. They are of distinct form. It is seen after cholecystectomy because of increased biliary reflux. The bile chelating and prokinetic drugs may be useful in the treatment, so they will avoid contact of the bile acid with the gastric mucosa for longer time and avoid reflux gastritis. Next, we have erosive gastritis. It is associated with non-steroidal anti-inflammatory drugs intake and alcohol. It is mainly produced by the inhibition of the cyclooxygenase type 1, which is also called as COX-1. So, COX-1 inhibition leads to the reduced prostaglandins, and prostaglandins are more useful for the gastric mucosal barrier maintenance. So, we have got now specific COX-2 inhibitors which will avoid COX-1 inhibition and which will avoid formation of erosive gastritis by maintaining the acid mucus barrier in the gastric mucosa. Next, we have got stress gastritis. It is because of severe illness or injury. The illness can be in form of sepsis, or injury can be in form of road traffic accident or any post-operative illness. It is by the reduction of blood supply to the gastric mucosa. So, the routine use of H2 receptor antagonist or proton pump inhibitors along with sucralfate, which is ulcer protective agent, can be used to prevent this condition. Next, we have Menetrier disease. Gauss hypertrophy of the gastric mucosal folds along with the mucus production and hypochlorhydria. It can be associated with hypoproteinemia and anemia. This condition is pre-malignant condition, only be treated only with gastrectomy. It is mainly caused by overexpression of transforming growth factor alpha, leads to the hypertrophy of gastric mucosal folds. So friends, we saw various types of gastritis. Now next condition is peptic ulceration. So remember, when you have got gastritis, it may proceed to the formation of various ulcers. So don't confuse between questions on gastritis and then two questions on peptic ulcers. So these are continuation of the same entity, but you have to specifically see the type A gastritis and type B gastritis, because both these type of gastritis, they may be asked on various questions. The peptic ulcer, it is so called because in addition to the acid being required for their occurrence, the pepsin also is required. So these both together form peptic ulcers. What are the most common sites? The first part of the duodenum and lesser curvature of the stomach. These are the most common site. So among all peptic ulcers, duodenal ulcer is the most common. So duodenal ulcer becomes the most common, hence the duodenum is the most common site. Next comes the stoma following gastric and esophageal surgeries. The next site remains the ectopic gastric mucosa seen in Meckel's diverticulum. What is the etiology? Presence of acid is the important. Hence in duodenal ulcers, acid secretion is more, but in gastric ulcer, the acid secretion is normal. So we have learned earlier in H. pylori infection, there is damage to this gastric mucosal barrier. So in spite of having normal acid secretion, the stomach can form gastric ulcers if the mucosal barrier is damaged. These ulcers are divided in acute and chronic. So we have got now acute peptic ulcers. We see now the etiology of acute peptic ulcers. It is caused by non-steroidal anti-inflammatory drugs, stress. The stress leads to Cushing's types and Curling's ulcers. Cushing types is seen in head injury and Curling's types are seen in burns. We'll see Cushing's ulcer later in detail. Acute peptic ulcers can also be caused by sepsis or steroids. Now Cushing ulcers. The common sites are stomach, esophagus and first part of duodenum. Note that it is not in distal duodenum. You may be asked question depending on what is the most common site of Cushing's ulcer of the following. So remember, these are the commonest sites, more prone for perforation than any other stress ulcers. Now we go to the chronic gastric ulcers. What is the etiology? First remains the non-steroidal anti-inflammatory drugs. Then comes the H. pylori infection. Then comes the enterogastric reflux. See, these all three are present in gastritis. So same etiology will come in chronic gastric ulcers. Then comes the mucosal trauma. Then comes diet and smoking and emotional factors and liver diseases. Chronic duodenal ulcer is caused by acid hypersecretion. There are various genetic factors like O blood group. Then we have got endocrine disorders like Zollinger-Ellison syndrome, hyperparathyroidism, multiple endocrine neoplasia type 1 and Cushing's syndrome. What is the location of peptic ulcers? As earlier we learned, first part of the duodenum is the most common site. Next comes the lesser curvature of the stomach. Then are the esophagogastric junction and the margins of the gastrojejunostomy or various stoma with the stomach. The common location amongst gastric ulcer is type 1 ulcer, which is present in lesser curvature. Now we will go to the duodenal ulcer. What is the incidence? It is now decreasing because along with the increased use of proton pump inhibitors, its incidence is decreasing along with the complications associated with duodenal ulcers. Pathology. Now most common site is the first part of duodenum. We may get two ulcers, both which are present on the anterior aspect and posterior aspect of the duodenum. These are called kissing ulcers. The anterior ulcer tend to perforate and cause perforative peritonitis. The posterior ulcers situated over the gastroduodenal artery, when it deeply burrows, may erode in the gastroduodenal artery and can cause torrential hemorrhage. Many times we may get giant duodenal ulcers when the ulcer is present throughout the circumference of the duodenum. When such ulcers perforate, they may give rise to the wide perforation of the duodenum. Mind, duodenal ulcers are always benign. As compared to the gastric ulcers, which may harbor malignancy, duodenal ulcers are always benign. Now we learn the gastric ulcers. It is less common than duodenal ulcer. Male and females are equally affected. They are common in elderly people. They are more common in low socioeconomic groups and hence in developing countries. The fibrosis produced by the chronic gastric ulcer leads to the contraction of the stomach and leads to the stenosis, classically called as hourglass stomach. Large ulcers may erode into pancreas, splenic artery, and rarely into the transverse colon. Chronic ulcers are common on the lesser curvature, as we saw earlier, especially at the insula angularis, at the boundary between acid secreting and non-acid secreting area. Now we go to the malignancy in gastric ulcers. In contrast to the duodenal ulcer, gastric ulcers are associated with malignancy. Benign ulcers can undergo malignant transformation, or the ulcer may be malignant from the beginning. So whenever you come across gastric ulcers, don't forget to take multiple biopsies from the gastric ulcer. Any gastric ulcer should be regarded as being malignant even if it appears benign. 10 well targeted biopsies should be taken before labeling it as a benign, and even further biopsy should be taken when the ulcer is healing and when it has also got healed. Modern anti-secretory agents can heal ulcerations with gastric ulcers, but obviously cannot be treated for the malignancy. What other ulcers we have got? We have got pre-pyloric ulcers. They are similar to duodenal ulcers in terms of acid secretions. They can harbor malignancy. Biopsy is required. Pyloric ulcers, they are similar to duodenal ulcers. They can be malignant, hence biopsy is required. Then stromal ulcers, they are found at the site of gastroenterostomy constructed in Billroth type 2, or they can be usually found on jejunal site of the stoma. So mostly these ulcers, they are found on the jejunal site of stoma, not on the gastric side of the stoma. So what are the clinical features of peptic ulcers? They cannot be differentiated. Gastric and duodenal ulcers cannot be differentiated on basis of symptoms. Patients may get pain which may be burning or may radiate to the back, or it is relieved by food, or it may be intermittent, or they may present with classical periodicity. What do you mean by periodicity? When the ulcer gets healed, patient may not get pain, or when the ulcer is in acute state, patient may get pain. It is the classical feature of untreated ulcer. It may relate to spontaneous healing of ulcer and spontaneous remission and relapse. Vomiting, it may not be usual feature. It may occur when stenosis develops. Weight loss. Patients with gastric ulcers are often underweight, or whenever there is malignancy underneath the gastric ulcer, patient may lose weight. Bleeding is the commonest complication of any ulcer. Chronic bleeding may present with anemia. Patient may have epigastric tenderness, or patient may directly present to you with the complications. How you diagnose? As taught to earlier, you diagnose it with ogiriscopy. It is the most sensitive investigation, and biopsy should be taken to rule out malignancy in case of gastric ulcers. Majority of uncomplicated ulcers are treated by the medical line of treatment. So what is the main treatment that we have got? We have got general measures, modification of lifestyle along with avoidance of smoking, alcohol, limited use of non-steroidal drugs, and excessive tea and coffee should be avoided. Then in pharmacological measures, we have got H2 receptor antagonist. Now most of the gastric ulcers or duodenal ulcers, they can be healed on few weeks of treatment. Only problem is relapse with H2 receptor, histamine receptor antagonist. The proton pump inhibitors, they have revolutionized this treatment. All ulcers will heal within 2 weeks of proton pump inhibitor therapy. Again, relapse is more common after cessation of the therapy. Eradication therapy, in most ulcers, H. pylori is the cause, as we saw earlier. Hence, this should be treated with the H. pylori eradication treatment as shown here. We have got regimens of bismuth compound along with antibiotics, which is metronidazole or amoxicillin, or we have got omeprazole, amoxicillin and clarithromycin, which has got more success rate. Patients in whom eradication therapy is not appropriate, these are non-steroidal anti-inflammatory drug associated ulcers, stomal ulcers and Zollinger-Ellison syndrome, where you have to tackle the definitive cause. Then what operations we have got for duodenal ulcers? The aim is to avoid damaging effect of the acid on the gastric mucosa. This can be achieved by two ways. Either you divert the acid away from the duodenum, or you reduce the secretory potential of the stomach, or combining the both. So this can be done by various operations like Billroth 2 gastrectomy. The first surgery Billroth 1 was done earlier. Then gastric recession with gastroduodenal anastomosis, and Billroth 2 gastrectomy, where it was discovered by accident. The gastroenterostomy was done in a gravely ill patient of pyloric cancer who was not expected to survive, but he did well, and they went on to resect the stomach. And the stomach distal to the anastomosis was resected, and they constructed gastrojejunostomy, which is omega loop. The antrum and distal body of the stomach is mobilized by opening the greater and lesser omentum, and duodenum is closed, and jejunum is anastomosis to the stomach in retrocolic fashion in Billroth 2 anastomosis. In Billroth 1 anastomosis, you resect the antrum and you make end-to-end anastomosis to the remaining stump of the duodenum to the stomach. Here the stomach is refashioned to take the shape of the duodenal stoma. We have got gastrojejunostomy. Because of the risk of mortality after gastrectomy, the gastrojejunostomy has found the mean way of between two. It deflects for alkali from small intestine, which will neutralize the acid in the stomach, and hence it will decrease the acid exposure of the stomach. It will promote ulcer healing in the duodenum. But the jejunum is directly exposed to acid and may form stromal ulcers. Next, we have got truncal vagotomy and drainage. It was the first procedure and was mainstay of treatment for many years. The principle of the operation is to section the vagus nerve, which is involved in the acid secretions, and it reduces maximal acid secretion by approximately 50%. Because the vagus is motor to the stomach, it may cause gastric paresis. Then we have to add the gastric drainage procedures along with this. These are pyloroplasty or gastrojejunostomy. Next, we have got selective vagotomy, in which the vagal trunk is transected along with hepatic and celiac branches are preserved, but it is now abandoned because drainage procedure is required. Next, we have got highly selective vagotomy. This is the only parietal cell mass of the stomach is denervated. Most satisfactory operation. It has got low incidence of side effect. It was gold standard of operation for duodenal ulcers in 1970. In this surgery, the nerve of Latarjet supplying to the antrum was preserved, and complete neurovascular clearance proximal to lesser curvature was carried out. The dissection is continued in the gastroesophageal junction, and lower 7 cm esophagus was also cleared of nerve fibers. Now these surgeries can be done with laparoscopy. Next, we have the truncal vagotomy and antrectomy. So truncal vagotomy is done and antrum of the stomach is removed. Recurrence rate are extremely low, but mortality was high. So if you were asked a question, which surgeries among these has the least recurrence rate, then the answer should be truncal vagotomy and antrectomy, even though this surgery may not be done nowadays.